Hello, everyone, and welcome back to another fireside chat regarding sleep telemedicine. And today specifically, we're going to be discussing telemedicine-based evaluation and a bit of management for insomnia. And similar to our previous case, this case comes from the AASM Sleep Telemedicine Implementation Guide 1 and 2 now with the new guide. I'm Barry Fields. I'm a sleep medicine provider at the Atlanta VA here in Atlanta, Georgia, and I'm also on the faculty at Emory University. And I am so happy to be bringing back the same team of all-stars that were with me for our two previous fireside chats as well. And I'd like to reintroduce them to all of you. So I'll just kind of go down the list here, and I'll ask first Dr. Donskoy, if you can introduce yourself.
Hi, I'm Inessa Donskoy. I'm a pediatric sleep medicine attending at Advocate Children's Hospital, which is located around the Chicagoland area.
Great. Okay, thanks, and welcome back. Next up is Mr. Dennis Kelly.
Hi, I'm Dennis Kelly. I'm an advanced practice provider, nurse practitioner with the Northeast Ohio VA Health Systems in Cleveland.
All right. So staying up north, let's head over to Connecticut and Dr. Christine Wan.
Hi, I'm Christine Wan. I'm a pulmonary critical care and sleep medicine faculty at Yale School of Medicine.
All right, welcome back. And we'll head down to the Southwest, Dr. Traster.
Hi, I'm Matt Traster. I'm one of the sleep and epilepsy neurologists at Barrow Neurological Institute at Phoenix Children's Hospital.
All right, and now back to Chicago, Dr. Marty Martin.
Yep, I'm Dr. Marty Martin. I'm a clinical psychologist specializing in behavioral sleep medicine, and then also an academic at DePaul University.
All right, thank you, sir. We really left an important person to the end there because this case really is looking more at behavioral health and utilizing telemedicine for the evaluation and management of insomnia. So without any further ado, let's go ahead and get started. So I'll be showing some slides and then I'll read the details from the case itself so you can follow along with me. So I want to introduce you to Mr. T. Mr. T is a 67-year-old retired business executive with a 30-year history of difficulty initiating and maintaining sleep. This is what he tells you. He was evaluated through a telemedicine sleep encounter with a sleep medicine provider. Prior to his visit, a comprehensive intake packet including validated questionnaires and a sleep diary was mailed to the patient. So let's stop there. And a few questions for Dr. Donskoy. So for you, how can patients get access to questionnaires electronically? And what portals are out there that, and how could even in-person patients benefit from those portals?
Thank you, Barry. For all of its downsides, this pandemic has really expedited a lot of advances we probably should have been and maybe were working on more slowly in telemedicine. And I would say electronic communication is a very, very big one. For those programs who weren't utilizing it prior to the pandemic, they have out of necessity started working with their electronic medical record or EMR systems and trying to find ways that providers can communicate and vice versa, patients can communicate back with their providers without needing to do what had to happen in this case, right, which is physically mailing out a questionnaire. So in our program specifically, we found a way to message our patients and have them message us back through the EMR and send attachments, essentially scanned in copies of the physical questionnaires we would have given them or would have mailed them, but now electronically sent as attachments. Of course, we then asked patients to print them out at home, fill them out at home. We did the same thing with the sleep logs that we would send out to them. And while this was a way for them to physically receive those forms without needing to come in prior to their visit, it's of course still cumbersome. And we learned how many of our patients don't have a printer at home in the process of doing this. So of course, there are better ways. And without needing to essentially reinvent the wheel, there are commercially available platforms that offer this sort of provider-patient ability to communicate. The AASM Telemedicine platform, or AASM TM, is one of them. And in that platform actually comes an integrated sleep log format. So that's just one example. There are, of course, other commercially available and sort of independent behavioral sleep treatment modalities that come with questionnaires and come with forms. But up to this point, they sort of have been hands off in terms of sleep medicine providers actively engaging. So really, I think this case is a nice example, and this pandemic has really been a real life example to all of us of kind of how much more work needs to be done to really have this smooth communication between patients and providers, specifically with questionnaires, and in this example, sleep logs. Right? We ask our patients to either keep the logs that we give them or print out the logs and have them near their alarm clock in the morning to fill out. What else is right there? Their phones, right? So we really need to continue this push towards technology and find ways to make our tech-savvy patients access sleep care easily, which really comes to your second question too. This poor Mr. T, look at him. He's stressed out, right? His work is playing a role in that, his family life. And of course, his sleep is suffering, which we all know is causing a new stress, right? The stress about sleep itself. And so when we offer him sleep services, we want to do it in a stress-free way. We want to do it in a way that we're not creating additional obstacles for him. He's always going to have to carve out that hour, for that first intake with a sleep provider. But why not do it from his home or from his office, where he can click in and click out and avoid a commute and avoid waiting in the waiting room on the front and the back end? Why not provide this care for him in a way that he'll really be able to access it so that more patients can access it? I think this time where we are really all forced to utilize telemedicine has shown us how convenient and how appropriate it can be for patients like this, where we potentially don't need a physical exam. And I think that we know better sleep is going to lead to better health outcomes. So I'm hoping that, providers, insurers, large medical systems, I'm hoping they're looking at all of this and realizing we could be definitely benefiting patients who would normally come for in-person encounters also.
Absolutely. I could not have said it any better. You said it a lot more clearly than I could have. I often think that, this is, to me, if telemedicine is used well, it's more patient-centered than what we were doing before. We're really thinking from the patient's perspective, how best to serve them, literally from where they're coming from, where they are, in their home, in their bedroom, wherever. So you brought up great points. So fantastic. So well, let me continue on with the case a little bit here and tell you a little bit more about Mr. T. So he has now completed the questionnaires and the sleep diary and sent them to us, and they reveal evidence of, as he told us, both sleep onset and sleep maintenance insomnia. Total sleep time is up there, 4 hours and 50 minutes with poor subjective sleep quality. During his telemedicine interview, Mr. T reported his sleep difficulties began during a period of high work and family stressors, which included frequent international travel and led to marital strain, right? How many times have we heard this? His clinician reviewed his lifestyle habits, medical history, medications, social and family histories in detail, and noted, as you see there at the bottom, that the patient exhibited moderately severe anxiety during the interview. So next question is going to be for Mr. Dennis Kelly. We have a few coming up. So one for you is, how can we monitor or confirm current and previous insomnia medications, which is a very important piece now that we're at this point in his management?
Well, I think this is one of the places where telemedicine can be a benefit and can also be somewhat of a limitation. Prior to our using more telemedicine, we would bring a patient into the clinic and they would bring a bag of medicine with them and we could do a pill count and kind of check and do these kinds of things. And Barry's kind of smiling because he knows in the VA how they come in with these giant bags from polypharmacy. And that's possible to do with telemedicine, but it's not the most efficient way or necessarily the best way. And so probably around 5 years ago or so now, the Congress of the United States decided that they would provide money to the states to develop some type of prescription monitoring program. And so they've designed and developed what are called PDMPs, or prescription drug monitoring programs. Currently, 49 states participate, as well as the District of Columbia, and all of our US citizens living in Guam are part of PMDs. And it's a wonderful system. You can log on. I know that for example, where I am in the state of Ohio, there is a mandatory program called OARS, and it's the Ohio Automatic RX Review System. And as a prescriber, if you want to prescribe particularly controlled substances, which is what these are mainly tasked to look at, you will register with OARS, and then they request that you do the inquiry. And not only can it show us what the patient is being prescribed in Ohio, but we have a cross connection with 37 different states in our system. And looking across the board, I've seen many, many states that have these programs, some of which are required and mandatory, others of which are can be done by individuals, but aren't necessarily mandated. Missouri is the only state which does not have this type of program, and their legislature determined that they felt it was a violation of patients' privacy rights and that the websites weren't necessarily robust enough, and they were concerned about breach of data, and so they don't make it mandatory for their particular providers. When you go to one of these sites, it's very interesting because it will show you all of the current prescriptions, when they were last filled, where they were filled, and it's particularly useful to look and see whether or not patients are getting prescriptions filled at multiple different pharmacies, which could indicate some potential abuse, although PDMPs can't necessarily provide that directly. And also will let providers know when it's time to refill these so they're not filled too quickly or too soon so that we don't have excess. Our particular program also will give us a score, gives us a score on narcotics, gives us a score on sedatives, stimulants, and an overall overdose score, which is an odds risk ratio that can help us to determine what the risk for patients may be, and do they require a little bit more close monitoring, and how are they doing, and it's interesting kind of to follow up with it. That will pretty much take care of your controlled substances. For non-controlled substances, most major pharmacy chains, and I checked with Walgreens, Walmart, CVS, and Rite Aid, and they all have programs that you can contact your local pharmacy and they'll run a patient profile for you to let you know what the patient's on, when they've had it last refilled, if they're being adherent to the medications, et cetera. And so that kind of cross covers us for the non-controlled substances. I also have suggested, and there'll be, I think at the end, a resource guide that lists all 49 state websites that you can contact for those of you that live in different states to see what your state requires and how you can access and register for the programs. And so I think that'll give us a pretty well seasoned overview of what's going on with both controlled and uncontrolled substances to see where our patients are.
Great. Really interesting that now more and more we're confronting these questions where we're treating patients from other states across borders, and we really do need to know what they're on, what they've been on, what's worked, what hasn't. And we all know that medication reconciliation is a key piece of safe patient care that unfortunately has been sorely overlooked, I think, in many areas in the past. So great to hear that there has been progress on that front. So let's move sort of to the next question that Mr. T brings to mind. We mentioned his anxiety level. So other questions that come up, these will be for Dr. Christine Wan. So how can we best assess for underlying psychological issues that could impact insomnia evaluation and treatment? And then again, considering those issues, is there a situation where you, Dr. Wan, would not want to proceed with telemedicine given any of those issues?
Yeah, I think this is an important question, especially for someone like me who practices sleep medicine, has a CBTI program, but may not be with psychiatry or psychology background. I think the important thing in a situation like that is to be able to recognize psychological issues that could impact your treatment for insomnia. In particular, things like depression and anxiety, as this patient may demonstrate. For us, as Dr. Donskoy was describing, telemedicine can be a very effective tool for screening because you can have these screening questionnaires sort of integrated into your practice that makes it really simple to screen at first pass for any of these psychological issues. For our program, we use just a simple 2-question questionnaire, screening questionnaire that's done by our virtual MA. And it just basically asks, do you have little pleasure in doing anything, or do you feel hopeless and depressed? And if they answer yes to that, it triggers an assessment by our nurse who can kind of log in and take a better history and an assessment of these answers. And then, part of that is having a pathway. If anyone is assessed to be a high risk for depression or anxiety, then they get into a pathway that leads them to an evaluation formally by our psychiatrist. So I think this is important because obviously, these psychological issues or psychiatric issues can definitely manifest as insomnia, and not that you can't do CBTI, but sort of a more well-rounded approach, also addressing their psychiatric or psychological issues would be I think best for the patient. We also employ an abuse screen as part of that initial telemedicine screen, and that's just, again, a couple of questions that ask, how safe you feel at home. And again, if they screen positive, it reflects this to an assessment by our nurse, and then a pathway for addressing that. And to your second question, Barry, that, if anyone screens positive, high risk for someone is likely to hurt themselves, hurt others, or feel unsafe in their environment, I think telemedicine is probably not the appropriate approach for caring for this patient. Also, if they're in an acute crisis with any psychiatric issues, then I think, again, that person needs to be seen in person for everyone's safety.
Yeah, I'm struck. As Dennis Kelly had said, he and I work within the VA system. And so sometimes I develop tunnel vision and think about what I'm doing in the VA system. But then I speak to others such as yourself and everyone else and many other folks I speak to outside the VA. And these issues are ubiquitous: anxiety, depression, especially during a pandemic. And they are comorbid with many disorders, including insomnia. And one point that I wanted to make also is, at least here in the VA system, and I think generally, this is not a screening that we do once, say the patient's okay for telemedicine-based insomnia treatment, and then go forward with that. We have an intake at every visit to check in with them. So maybe the patient was appropriate for telemedicine-based insomnia care, but maybe they're not anymore. We all know our lives are dynamic, so are patients' lives. So I just wanted to reiterate how important it is to continuously reevaluate to ensure that you're able to, number one, keep the patient safe, but also number two, of course, continue to maintain progress in an effective way using telemedicine. And one of the ways to do that is to continue checking in with the patient regarding their general mental health, kind of as you go along. And, you know, as you see in this presentation and everyone watching, we've sort of assigned questions to each person, and I've been moving along, but I do want to stop just for a moment to see if anyone else has any other input, particularly for a topic like this. Anyone else have anything to share here for psychological management and sort of identifying patients for or not for telemedicine?
I think Dr. Wan put it beautifully, right? It's not even necessarily only the patient's own mental state, but their safety. So in pediatrics, this is a time when we really want to make sure that our patient, the child, is safe in the environment. And that might not be something that you know the answer to until you're in the visit and you're hearing or witnessing certain things throughout the virtual encounter that, you know, give you pause and make you concerned for that child's safety. And then, of course, we have our own kind of pathway of who to notify in a similar fashion as Dr. Wan. But the safety aspect, I think, is a really important one that we don't think about often enough. And that could be the safety of an adult patient as well, depending on what's going on behind them or what you're hearing in their household.
And then for me, often I'll also look at substance abuse and use as well, because for a lot of patients, about the only way that they can actually initiate sleep is through the use of substances. So that's often the check that I will do as well. And that has implications for safety, depending upon what their occupation is and their driving habits too.
I also think it's important to consider when we look at insomnia in general, is it a symptom of something more serious and something that we may want to look into, in greater depth, and then, to again, look at those safety issues as it may be a symptom of something else. We in the VA are pretty much been primed lately because of the number of veteran suicides that, we do the suicide screen each time, but we also need to consider, could this be a symptom of something more serious?
We are definitely reaching veterans who may not have wanted to travel before, so they wouldn't travel for insomnia treatment. That also was a potential opportunity to find other types of psychiatric disease or other issues. And now we can potentially use telemedicine as a tool to make it, help with access, make it easier for people to see us and potentially pick up more of these other comorbid issues. So thank you for that. All right, so let's move on with our case a little bit more. So going on with Mr. T, our unfortunate patient who's really struggling here with his insomnia. The patient elected to enroll in an online cognitive behavioral therapy for insomnia, or CBTI program, which included use of stimulus control, sleep compression, and mindfulness training. And we don't get too many more specifics at this point about what that program is. So the next questions are for me. So the questions that I'm going to address briefly are: what data exists that this type of sleep telemedicine may be useful? And what are the variants, I call them the different flavors of sleep telemedicine that can be useful in this setting? So the first question about data that exists for this type of sleep telemedicine. So the most recent data I could find appears here. You can see it pop up. There was a study published just a few months ago, actually, in the journal Sleep out of Michigan, I believe. And they looked at patients with insomnia. And some patients came into the practice to see the psychologist most of the time, the provider of CBTI. And the other group of patients were randomized to telemedicine-based CBTI. So at the top here, you see CBT-TM, so that's CBT through telemedicine. And then there's CBT F2F, which is face-to-face, in person. And their primary outcome measure was the Insomnia Severity Index, or ISI, which is a 28-point scale. Many of you are familiar with it, looking at various symptoms of insomnia. And they had other measurements as well, but that was the primary outcome measure. And they looked from the beginning of the study to the time the patient finished treatment and compared the ISI results. And then they looked 3 months later to see if the results were maintained. Then they said, all right, which is better, face-to-face or telemedicine? And you can see here, so on the left, you see it says post-treatment. So those were numbers obtained right after the treatment was completed. Below it is 3 months after follow-up. And you see those numbers, those are differences. Those are, and you can see the caption there. These are the non-inferiority results. These are the difference in ISI scores between the conditions. And you can see it didn't matter. In other words, telemedicine-based CBTI, and this is real-time audiovisual communication, is not inferior to in-person, face-to-face care for insomnia. The study is not looking at superiority. It is not claiming that it is better to do telemedicine. It is merely stating that telemedicine, in this case, with this group of people, was not inferior to the results that you get through face-to-face or in-person care. So this was a very interesting study because there are not a lot of head-to-head studies, telemedicine versus in-person care. The other thing I really liked about this study is they define very clearly what they mean by telemedicine. And this gets at the second question that I sort of asked myself awkwardly in the previous slide. So I asked myself, what are the different types of telemedicine? What are the flavors? So when someone comes up to me and says, I read a study and it says that telemedicine is just as good as in-person care for X, Y, and Z. To me, that's like saying, I looked at the patient's blood work and it was fine. All right, well, what do you mean by blood work? What did you test? What do you mean by telemedicine? Like, there are many different flavors of telemedicine. So there is something similar to what we're doing now, which is video, audio, real-time audio-visual communication. This will not be real-time. This will be recorded, but something similar to this and what was done in this study. Technically, the CBTI could be done over the telephone, and you can call that telemedicine. CBTI could be done through an app on a phone, which we'll be hearing more about. You can call that telemedicine. So what are you talking about is very, very important. And just recently in the past year, there was this article that was put out in the Sleep Medicine Clinics Journal. It was a review of telemedicine and the management of insomnia. And they get at this to say, don't just tell me telemedicine, tell me what you mean. So at the top of this inverted triangle, self-directed telemedicine is basically you're just using a mobile app. There's nobody talking to you synchronously or asynchronously. Then you move down. Let's look at, for instance, the third one down, fully directed, but a group. So here the support is moderated on the web or through video conferencing. So now we're actually adding some interactive video conferencing. And then at the bottom is basically what I showed you on the left. The primary support, this is fully directed individual treatment for insomnia. The primary support is through the web or a one-on-one video session, similar to what we're doing now, but it would be done synchronously. And then there can be telephone and asynchronous texting, email chatting as support of that. But it's just really hard to summarize the evidence because there's so much heterogeneity in study designs and also study methods, what's actually being used. So there is good data now that real-time face-to-face telemedicine for CBTI is probably just about as good as in-person care. There is some research also, I'm not going to go through all of it, looking at some apps as well and some online portals and modules for CBTI, which we'll talk about shortly. And many of them seem to tell a similar story, which is that it's nice if you have some personal one-on-one component, even if it's just video, but there have been some good results even in just people who might not otherwise have accessed any care for their insomnia. At least if they're using an app or some kind of online tool, you do actually see some results that can actually last over time. It is good though to have patients see a provider to guide them through that pathway, seeing the provider either in person or through video-based, synchronous, real-time telemedicine. So the data is there. If I were a patient, I would feel very comfortable doing telemedicine-based care for my insomnia, especially as long as there is a one-on-one, face-to-face component for it, given the data available. Okay, so that's my little soliloquy. Let's move on to our next to the last question and answer little period here from Dr. Matthew Traister. So moving on to some questions for you, Dr. Traister, out there in Arizona. So how can you find an online CBTI program? I just alluded to them a little bit. What's the typical cost? Do some come as apps? And again, I kind of touched on this just a little bit. How do we know they're evidence-based if you're going to be taking part in them?
All right, so all great questions, Barry. I think to find an online CBTI program, I'd recommend you talk to your sleep health professional about these, but I have a few favorites. And of course, my opinions don't represent any sort of a AASM endorsement. And there's several kind of do-it-yourself cognitive behavioral health apps for insomnia, where do-it-yourself means you don't necessarily have to go see a psychologist or a therapist. And I think these things probably cause my psychologist pal, Dr. Marty Martin, physical pain, but I think they can be helpful in situations where access to behavioral health providers is limited. I will say, though, I think there is absolutely no substitute for a truly skilled and sympathetic psychologist guiding you through some of these techniques, whether that be in person or via a telemedicine encounter. So I'll talk first about some of the pay apps, and then I'll get into some of the ones that are free. And if you don't like things that are free, and I think that's a valid concern, as some people worry about surrendered privacy that may come along with an app that doesn't necessarily charge you up front. There's several well-respected pay apps that you can use either on a web-based use or a application-based use. And I think the one with the most data used to be called SHUTI, SHUTI. It's called Sleep Healthy Using the Internet. It's now called Some Rest or Somrest. If you get some rest is like, I think their little gist there. That is a pay service. It's not cheap. There's an initial $45 consult fee, and then it costs you $899. Now you can have your sleep doctor do the original prescription and avoid the $45 fee, but you still have to pay for it. This is FDA approved as of November 2020, and it's the only one of these out there of which I am aware that has this kind of FDA approval. And there is scads of research backing the utility of this product. I personally know a handful of satisfied customers, both kids and adults. So it's the real deal, but it's not cheap. It's not for everybody. And while it may be something you could submit to your healthcare flexible spending account, it's not something that's typically covered by insurance. My personal other preferred pay app is one called Sleepio. This also has some peer-reviewed research backup from Dr. Espy, who's the founder, which I think is very legitimate, and all PubMed type based documents that support its use. Now, this one, if you dig really deep on their website, you can kind of figure out how you can get it on your own for about $400. But this company's business model has been primarily to provide this as like a service through your human resources department or your employer. So they tend to be something that is offered, institutionally. You don't have to have a prescription to use it. But again, it is another kind of self-guided cognitive behavioral therapy for insomnia that has a decent amount of data to back up what they're trying to do. There are others. Again, most of these are applications, and I'll mention them by name, and I'm not leaving anybody out intentionally, but there's one called Better Night, one called Dr. Lullaby, one called Night Owl. And then also if you just, type in Insomnia into the App Store for Apple or the Google Play Store for Android, you'll see all kinds of options that come up. And these are anything from mindfulness to, particular sound type apps. Or someone reading you a boring story. It's all kinds of stuff that sort of come up that can help a little bit with sleep. For my older patients and for adults that I encounter, I think one of the most useful things, and I know that Dennis and Barry are familiar with this, is the Stanford and VA collaboration called CBTI Coach. And this is an app that you can download again from Apple or from Google Play. It is a wonderful, cognitive behavioral therapy for insomnia that has a lot of really great tools that is really useful. There are PubMed articles that support its effectiveness. As far as the research that went into the creation of the application, that's harder for me to kind of like ascertain the data points behind it, but they're using proven techniques that are well established. So I find that one very, very good. Again, I think it's a little more geared toward adults. There is a Canadian web-based application, so not a smartphone app, and it's called dozeapp.ca. So literally www.dozeapp, dozeapp.ca. And this is sponsored by the Canadian Institutes of Health Research and Ryerson University, and it is geared much more towards kids. And it's very interactive. It's very useful. You kind of start by doing a sleep diary, and then it starts to give you prompts as to what you may or may not be doing right or wrong. And this one does have a clinicaltrials.gov identifier, which has been recruiting since roughly May of 2019, but they don't have any data or anything published at this point. So for me, that's the ones that I tend to go to the most. And again, my comments here don't represent an endorsement of the American Academy of Sleep Medicine, but I do think there's lots of evidence out there that these things work. And I think you can feel pretty confident if you stick to some of the things we talked about here, that you're getting a product that's tried and true.
Great. Thank you for that review so much. More out there than I was even aware of, and fascinating different parts of the market that have really developed with this, and I think only become more active over the past year or two. So some really great stuff to look at online there. So thank you. All right, so we're going to move along a bit more and kind of finish up our story with Mr. T. So Mr. T purchased a wearable fitness tracker and reviewed the data with his sleep provider. Results were generally consistent with sleep. With periodic telemedicine visits with his sleep provider, he demonstrated improved objective sleep parameters over time. So wearable devices, fitness trackers. So these questions are for Dr. Marty Martin. So how do providers get access to patients' wearable device data, whether worn on the wrist or the finger or whatever? And do you have any experience with patients who are providing you with this data?
Yep. So let me answer the first one. And the first one, it's not easy to get access to it. So I'm going to set aside kind of privacy and security issues for a moment, but come back to that. So I have had patients send me the data, and then when they send you the data, it all depends upon how they download it. And they can download it in multiple different types of files. I have had patients print it out and mail it to me. I've had patients download it and then PDF it to me. I had one fax it to me. And in some cases, they can make you a guest to their account. And then as a guest to your account, you can see it. And then you have platforms like the American Academy of Sleep Medicine TM platform, where the data, Fitbit data, is uploaded. So there's a whole variety of ways that you can get access to the data. I think my fear is this, is that with the Internet of Things, you can get sleep data from Alexa, you can get it from your bed, you can get it from your pillow, you can get it from your wearable. So the kind of the conundrum is going to be is, how do you make sense of all that particular data? Now, with regard to the confidentiality and the privacy, is I don't like to go to a patient's site in the portal and to kind of play around with their site or portal. So I don't do that. So I think it's important to always think about the confidentiality and security issues when you are accessing the data. Another point on the data is this, is that in a lot of cases is you have to think about is it more continuous data or is it a snapshot in time? So is it truly representative of actually what's happening? The other thing is, are there any artifacts in the data as well? So you don't want to kind of go forward and assume that the data has full validity and veracity. You want to ask some questions about the data. So typically what I will do is when reviewing that particular data, I want to find out from the patient, how does it fit with their own experience? So they may overrule the data, if you will. I think the other concern is this, that I'm finding an increasing number of patients where they're too data focused, and what's happening is they're almost hypervigilant about the data. And I have one engineering patient, and he was spending a good hour and a half a day doing intercorrelations, regression analyses on not just sleep data, but he had HRV data and blood pressure data and motion data and GPS data. I think he thought it was intellectually interesting to him, but he became very, very overly focused on sleep in his life. So what I recommended is, tell you what, for just 2 weeks, why don't we not look at the data and just kind of find out from your own internal experience as to what you think is happening. And he happened to sleep a little bit better because he wasn't overly focused on it. So with regard to the experience, I'm finding that with the wearables and the trackers is that more and more patients are expecting or asking, will I actually look at that data? And I do, although it's not an easy thing to do. And I think the other challenge is it consumes quite a bit of time as well, because it depends upon the file format and how they distribute it to you. So it can be very time consuming. But I definitely think, going back to Dr. Donofsky's point, is that if we can have some platforms such that the data is easier for providers of all types to be able to take a look at and look for patterns, it'll be all the better, as well as perhaps having patients really look at data that's meaningful with regard to what their particular outcomes may happen to be. So those would be my thoughts about what's happening with the Internet of Things and all this patient data that's floating around from wearables and trackers.
Yeah, exactly. All the technology is there, and so many of my patients are aware of it, but it can kind of create new conundrums. And it's so interesting. I hadn't thought that, people lose sleep over losing sleep. And this is another way to inform people, hey, you're losing sleep, so you better worry about it. And that
Right.
can only make things worse. So really great points there, and really interesting to see some of the cutting edge nature of this stuff that's coming out all the time. I mean, clearly there's a market for it. So, all right, so let's summarize what we've been talking about and where we're going. So just some key learning points. There is a dramatic and unmet need for specialty insomnia care, and telemedicine may afford increased access to this care. Insomnia, as you've seen, is highly amenable to telemedicine management, and treatment may be aligned with existing telemedicine resources for mental and behavioral health disorders, such as anxiety and depression, which we talked about. Sleep diaries, sleep questionnaires, and wearable devices, fitness trackers can augment clinical decision-making during telemedicine encounters for insomnia. And online cognitive behavioral therapy programs and other internet resources may offer additional tools, and you heard this from Dr. Traster, to help care for patients with insomnia. And with that, I will stop there. I will again thank the entire panel of experts for joining me today. And I thank you for joining for this presentation. And I also invite you to join us for our next fireside chat. I won't tell you what the topic is, so I'll keep you in suspense. So please join us next time to have a look at that with us. And just a reminder, Dennis Kelly has provided us some information about PDMP that will be appearing at the end of this presentation. So thanks so much again, and we will see you soon.